Welcome to another episode of The Breakdown. Oh boy. This is going to be quite the conversation we're going to have here today, and we're going to get right into it. Some of you might remember just a little while ago, The Breakdown leaked a document that it caused a little bit of a furor. Some folks were not very happy that document got out. We're very excited to have with us today the author of that document who did not give it to us. To be absolutely clear, we did not get the document from our guest today. We have other options. But very excited to welcome back to the program, ER physician, and my understanding, president-elect of the section of emergency medicine for the Alberta Medical Association, Dr. Paul Parks. Dr. Parks, thank you so much for joining us today.
Yeah, thanks for having me. It's kind of like maybe the AMA is like the mafia. Once you get in, they don't ever let you out, right? I'm
I was I was gonna say you go from president of the AMA to president of the section of emergency medicine. Like that's this is some masochism there going on, perhaps.
Yeah, I'm just stupid enough to not say no. I've done that role lots before, but maybe part of it is just natural fit with the advocacy and stuff I've been doing as well, right?
Yeah, for sure. So let's talk about that because again, as I said earlier, to give full, I don't know, transparency, we did not get the document from you. So anybody who wants to be like, oh, that Dr. Parks was teaming up with the breakdown, that's not what happened at all. But let's talk. I want to talk about this document. I want to talk about sort of what was the impetus for it, what was the development for it, and how many phone calls have you gotten saying, God damn it, how did that get out there? So let's start with the impetus for it. How did this thing get created?
So, I mean, I was the impetus and forced to ask my colleagues to get some of these cases. I will say right off the get go, like, yeah, so I am representing emerged docs across the province, speaking on behalf of our experience. Well, almost all of this is my own personal opinion with the input of my colleagues. I say that in a bit of a way too, though. I want to say that I'm expressing my personal opinion here, but it's not just, Paul Parks Chicken Little saying the sky's falling here. Like I want to be really clear, like hundreds of physicians and colleagues in internal medicine and hospitalists and surgery, they're calling and reaching out to me and saying things are really bad. And that's a bit of an understatement. Like things are disastrous. So after the very public, like things have been bad, I gotta say right off the get-go, we've been struggling for over a year or longer. Our system's been in trouble. We've been trying to advocate internally. We've been trying to go through the right chains, the chaos of refocusing, which we've talked about before. And I was a little bit polite about saying, hey, let's fingers crossed it's going to work at some point. I'll tell you, 2.5 years in now, we're seeing how that disintegration and that discoordination is really impacting frontline care on every day. And we can talk about like concrete examples, but we were saying it's really really bad in the system for the last year. Really trying to get help. In the summer, we never got our natural kind of reprieve where things came down. Our hospitals were still really overcrowded, and we saw the gong show that was going in Australia. Our summers, their winter, they were getting a terrible influenza. They were getting hit hard. We knew a bad influenza was coming too. So we were trying to advocate more and more. And then fast forward to going into the seasonal, it hit us a bit earlier than anybody was prepared for. It was, I want to say this right off the get go, influenza did not all of a sudden caused this. The system was struggling and really bad. Influenza was the 1,000-pound weight that landed on the broken back of the camel that was already broken. It made things just infinitely worse. But fast forward to that tragic case of Mr. Sri Kumar that was very public, very everybody aware. And for those that may have not have heard of it, which I would be hard to at this point, but it was, someone in their 40s who went into the waiting room and with severe chest pain and waited over 8 hours, and then by the time they got into a care space, had a cardiac arrest and died. And I'm not going to speak to his case in particulars because I didn't care for him. I don't have inside information, but on the cases that we collected after that, I do have inside information on a lot of it, and I do have a lot of experience to talk about why these cases could happen. But I just want to say, after that case, many of my colleagues reached out to me and said, Paul, but for the grace of God, there go I or my team. That could have been any of us. We're seeing that regularly. We're seeing those kind of examples regularly. So that was the impetus for me to say, listen, we really got to put a human face on this. That there's so many stats. There's so many. You can talk about capacity and EMS offload time and red alert time and EIPs and ALCs and blah 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 blah. Uh, every one of those cases that is in there are human beings. They're Albertans that some died of causes that my colleagues are very, confident that maybe we could have prevented that. Many of them are near misses. We wanted to put a human face on it and try to impress upon the government the urgency and have them share the urgency of what we're experiencing. And so that was the drive to get those cases out. So that was a bit of a long answer to say. And those were collected in less than a couple of weeks by colleagues across the province, multiple different emerge departments, many colleagues sending them to me so that I could anonymize them enough so that there's not patient identifying factors. You don't know when they were seen, where they were seen. But I verify and vouch for all those cases and the people that sent them to me that they're real and they're just the tip of the iceberg of what we're seeing.
I love that you emphasize the flu piece because that's been one thing that we've certainly seen some of the talking heads lean into the whole idea of, oh, it was the respiratory flu season that pushed the healthcare system over the brink, but it's okay. We didn't have to cancel any surgeries, so everything was fine the whole time. And it really, really wasn't a function of the flu season. And I go back again. I talked about this on Sunday's show, but I go back again. Like I was very ill about a week and a half ago, where I had some sort of illy type influenza-like illness type thing, and I did not end up going to the emergency room. And a lot of people who do go to the emergency room for illy stuff, those are the ones who are waiting in the waiting rooms because their presentation isn't high enough that they're we need to get you in right away because you have the sniffles. And not to diminish it, it was a horrible experience. I did not
Oh,
like it, but do not
that
get me.
that influenza was nasty. It hit people hard, and I'll say too, I like lots of people had just kicked the crap out of them and made them feel very, very ill. It did definitely bump up our need for admission though in our elderly and our children because those that extremes of age, and so it did add a burden to our system. But I just want to highlight exactly what you said. We know every season, every winter, we have a spike go in our admissions and our need to go to the hospital, get seen and emerge and be admitted. That's part of the reason that we need to have some surge capacity, that we need to be able to always expand. And so yeah, this influenza was just another major stressor, but it was not in any way the key one. And so it's just very important people understand that.
I want to talk about some of these cases because, and full disclosure here, I mean, I introduced you as working an emergency physician and president of all the things. I work professionally as a paramedic. I'm speaking only for myself, not any organizations that I represent. Although apparently with the new laws, I don't know if I still have to say that. It's all very confusing. I'm going to say it anyways because I think transparency is important. But I want to talk about some of these cases because in reading them, and it's I can't like not have the medical knowledge that I do in reading them. The first like five, six, it's like holy hell. Um, and I think it's important to spend some time fleshing out. Like we've seen some ministers, and I'm going to talk about Big Nixon towards the end of this conversation.
Oh, let's please talk about that for sure. Yes.
But we've seen some ministers try to minimize some of these things and like, oh well, we don't know and rena. The first one, the left without being seen tragedy. This talks about a gentleman in his 50s. He presented with the fever, the sore throat, that stuff's boring. The intermittent confusion, that starts to get my attention. The
Absolutely.
falls from generalized weakness. And then it's really the vital signs that are like, oh, that's not great. Because his demonstrated tachycardia for the lay people, that's the fast heart rate. His heart rate was 136. That's getting close to double what a normal resting heart rate should be, if not double what a normal resting heart rate should
Correct.
be. He's breathing quickly, faster than he should be, and he was waiting for 7 to 8 hours in the waiting room. Um, it, that's kind of bonkers.
It is, and every single one of those cases, if you're medical in any way, and you're EMS, emerge, anybody that works I'm almost anybody medical reading those cases, each one is horrifying in their own, and each one of them is these are sick people. These are so, and again, these are the tip of the iceberg. My colleagues sent, like, I was really surprised that some of my colleagues sent some examples of death, because we all see it and we know it, and we're quite leery to report it, because then a lot of bad stuff happened. And that I said I should be qualified. We report it internally, and we tell the triage nurses, and it goes up the chain, and we say this is bad because overcrowding is causing these big things. But we're not we're leery to shout it to the mountaintops and talk about it in the public. But the key is every one of those is horrifying, and should really distress people, and then add them all together as just a snapshot of how bad it is across the province. But that's a great example. So now I want to talk about these, though, because the knee jerk for someone out there would be like, well, how could somebody not know that this person is sick? I guarantee you the triage nurses and anybody that looked at that, I guarantee it. Like a brand new nurse getting their first day of triage would know that that's a sick person, and there's infection going on, or something, but probably infection, needs fluids and antibiotics quick, needs to get seen, needs things done. In that day, on that given day, I'm not saying what hospital it was or anything. I'm just making up random examples to be that maybe there were 70 other people in the waiting room at that day. And some of them were having 10 out of 10 chest pain, like Mr. Sri Kumar, and some of them were traumas coming in. And then some of them were that same presentation, but their oxygen level was 80. So really low, so below 90. So we know they need oxygen quicker, and so they got bumped in. The key part of all this is that a functional emerge department, that person would have been, for sure, they were registered as CTAS 2, no question. And in a functional emerge department, in an aspirational level, every one of patients like that would be seen in 30 minutes by a physician, having stuff initiated. We know time to antibiotics is life-saving, and for every hour delay, it increases mortality, like dying. We know all these things. In a functional emerge department, where there's space, that patient would be seen in a half hour. That's aspirational, but guaranteed an hour max. Like, the people would know, and we'd move spaces and get people in there and take care of them. In that given day, there was probably, I'll just pick a random. If it was the Royal Alex, has 65 care spaces. They regularly, during this time frame, Royal Alex had 55 admitted patients and 15 patients consulted out of 65 beds. So you're talking 70 really sick patients stuck, stranded in the emerge. They would have many patients that you and your colleagues have brought to EMS offload, lining the hallways. And as an example, again, I'm not saying this case happened at the Relax. I'm just using generalized examples that we've had days where the Royal Access had 100, 110 patients registered in the waiting room. Think of that chaos and think of what that background is, and then read that case. And then, of course, the next step is he's delirious. He's not thinking properly. He's really uncomfortable. Have you ever been that sick? Can you imagine sitting in a waiting room chair for that long? He leaves and goes home, and then hours later is even, more sick and almost pre-dead by the time he comes in, and then quickly, despite our best efforts, dies.
And I think the thing that's so striking about this case, because and I want to be clear, eh, there is a uncomfortable part of this conversation that unfortunately the government seems to have leaned into, where they're like, people go to the ER, sometimes they're sick, they die, and that's true. There
Right.
are presentations, tons of different types of presentations, where despite the best efforts, there is nothing, there are no interventions that are going to change this person's outcome.
Absolutely.
And sometimes there's interventions that are just purely making that person comfortable, because that outcome is unavoidable, it's inevitable. Um, and that does happen. But that's not what we're talking about here, because the diagnosis that was listed in here is strep bacteremia, and so he had a bacterial infection that, if had it been caught earlier, there is a reasonable probability that antibiotics and everything else could have prevented his death. Is that a fair statement to make?
100%. And again, that's why you're, a paramedic and EMS. That's why I'm an emergency physician. That's why we have emergency services. Is we are very skilled at that kind of thing. We are very good at, when people present, identifying that, working up, getting things. We have amazing antibiotics and supportive measures. And yes, and again, these are human beings, these examples. And so one of the things that gets missed in that list a little bit, that it's buried a bit more at the end maybe too, but gets missed in the big picture, is just picture 8 hours in a waiting room feeling that terrible and not even having comfort measures and not even having like a bed to lie down and maybe a blanket. He probably had a fever, but regardless, some comfort measures at a minimum, never mind the intervention and the life-saving things that we know. And I want to say again too, my colleagues, like the examples they're providing, like, yes, we do see, I personally, all of us have seen patients that come in and we're not going to save their life, and that happens, and we're going to make them so that they don't suffer, and that so their passing is comfortable and their family's experience of that is mitigated as best as we can, and make it as painless as we possibly can. That's what we do. Yes, that happens, but to even remotely kind of suggest that, oh, some of these the concerns we're raising, or it's just a bunch of people that were going to die anyway. If that's the stance and the response from government and ministers and PR, then they absolutely are not hearing our message, and God help us. And that's why we're pleading for help.
Yeah. To me, it's an incredibly callous thing to go right to, well, sick people show up to the ER and they die sometimes. And I mean, yes, technically that's true, but
Absolutely.
that should not be the first argument or justification that any if I tried to do that as a professional, or if any healthcare professional tried to do that in response to a negative outcome, sometimes people die. Holy cow, would I be in so much trouble? Um,
Oh, I know, and yeah. Well, you know what? Let's be even more blunt. I got to tell you, like, so my colleagues and I are a little bit frustrated. Well, a lot, not surprised, but frustrated too. You got to understand. So we were internally advocating, trying to get things going, and then of course we come out, and so there's a couple pieces here. So some people might say, why does that list exist? Part of it was to try to get the government's attention to share our urgent sense of urgency, but in addition, we had come out and said that, publicly, it's an environment where very few healthcare workers want to actually talk publicly, and they're worried about their jobs, and they're worried about punitive action, and they don't want to speak out. But we had come out, and internal medicine docs who didn't want to be identified went to the Globe and talked to them about how bad it was in the hospitals, and they asked me, and we said, yes, it should be. We should declare that we are in a state of crisis, disaster, emergency. We should just declare that it is. Use our tools that we have provincially. We need to coordinate our responses. We need to have a leader accountable to help us through this. We are in a state of emergency. We declared it. We brought it out. And what's the first thing government does a couple days after? They take a couple days. They send out their PR people, and they gaslight us. And they literally say we're misguided. That's direct quote, misguided, and then that everything that possibly can be being done is being done. And then in addition, yes, we have provincial control, and the things that we need to do to load level and all the things that we could do, we're doing that. So and then what happens is they try to gaslight, try to basically undermine the couple voices that are out there. So we get other leaders, internal medicine and emerge, write an op-ed that say, no, we really are in a state. And then we get hundreds of physicians to actually sign and say, no, we support this. Like the physicians that work in the hospital, we really are in this state of, and again, Nate, I really want to stress this. I truly don't give a darn. Don't give a damn what they call it. If they want to call it a state of emergency, a state of crisis, a state of disaster, or extreme pressure, I don't care about the semantics. I truly don't. Just acknowledge it, and then let's form a plan to act. But it took them 10 days for the first minister to come out. And then does he say, "Oh, we were misguided by calling them misguided"? No, no. They in the end confirm our concerns that it's extreme pressure. They do admit that we may not have a single point of provincial control. There are maybe other things we can do to load level. And then it's just kind of a little trickle here and there to try to downplay the concern from the public. But yeah, the gaslighting and the just not listening and not responding and sharing our urgency is why that list exists as an example. Like many people criticize me for collecting it. I did not leak it. I totally understand why it got leaked though, because it went up the chain. I'll just tell you guys right now, there's not been a single premier got it, ministers got it, and ACA leads got it, and no one's responded that even acknowledged receipt.
Here's what you gave me so much to unpack there. It- like the misguided piece to me is particularly bonkers because to say that a physician, a nurse, a healthcare worker, whatever, who is trying to advocate for the best possible circumstances inside of the healthcare system, inside of emergency rooms. I mean, there's no other motivation, especially given the climate that you've described, where people are fearful of speaking out because of potential consequences. And I mean, I certainly have heard rumors that sometimes the premier's office likes to reach down and say maybe you should fire certain people. I don't know. I do. But to say that somebody who's advocating for people to get the care that they deserve is misguided is quite a tacit admission that I don't think they necessarily intended to make. But the other piece that's fascinating to me is that the their the narrative has changed. The government's narrative has changed because Matt Jones came out and he was like, "Oh no, everything's fine. We're doing great. We haven't had to cancel any surgeries." And then at a follow-up press conference, which by the way, it is bonkers to me that any minister or any press secretary has the audacity to try to say to journalists, you're only allowed to ask questions on these topics. That's some dystopian Orwellian nonsense. Like you could say, oh, it was the press secretary who said that. That's fine, but the minister stood there and let that happen, and that's on him. So I'm still gonna like, hey, Matt Jones, get your act together with that sort of anti-democratic crap. But for him to say at that press go, yeah, okay, well, maybe we do need some provincial coordination. Maybe we do need some. They have started with the premise of we have to blow up the healthcare system and worked their way all the way back to okay, maybe some provincial coordination is actually a good thing. And it's taken, as you said, 2.5 years to get there. And
Absolutely.
I look at this list and I go, and this is the consequences.
Absolutely. And the ownership and accountability falls 100% right on the premier's lap. She blew everything up. She went in saying she would. She blew up the entire system, spent 2.5 years of constant chaos, reorganizing, firing hundreds of skilled leaders, parceling everything up, fragmenting everything up. And to the point where, so they set up things like the acute care agency and created some legislation and think of these nice big, ivory tower ideas that maybe the ACA is going to be able to help coordinate things. Well, like I'll tell you, before those cases got out and as we were declaring a state of emergency, and that we were in it, and I want to really say, so I'm not quibbling with this. We said we're in a state of emergency. It's a disaster. We need to activate provincial coordination of the things that we know we can do, like load leveling, repatriation, maybe canceling some scheduled surgeries. There's a bunch of things we could do that we've done in the past when AHS ran the whole province and had an ability to do it provincially. We didn't say call in the military. We didn't say call the feds and declare another pandemic state of emergency. Nothing like this. So we were very clear on the ask. But here's the thing: is that while we were doing this internally, I went up to the leads of ACA and saying, who is operationally in control to help us do day-to-day operational things when we're in trouble. And so let me give you a very concrete example. And I'm sure you can see and you can live this is that picture there's someone in prior to this, we had what we called IOCs. So integrated operational centers or controls that they was one in Edmonton, one in Calgary. They connected together and then it connected all the zones together. And they were literally the operational day-to-day people saying, okay, it looks like Edmonton zone is drowning. It's really bad for these numbers and this and things are terrible. So we're going to do these things in Edmonton, but then provincially we're going to bypass them. We're going to do certain things and they would do that on a day-to-day level. That got blown up by a senior, very, very senior administrator. Their words were the government effed that up beyond all recognition, foobarred it. And so that's where we're at. Now, picture a real example what's happening in the last month. Sick patient in Hinton, say, I don't care where, anywhere north of Red Deer all the way to the Northwest Territories. If they're really sick, they got to go into Edmonton. So someone's sick in Edmonton, in Edson, let's just pick. Edson doctor phones the U of A, talks to one of my colleagues, a merge doc in internal medicine. I got to send them in. They're really sick. They need this. Both doctors on the phone say, yeah, you definitely do, but we're full. We can't take it. So then they call the Alex, same answer. Then they call the nuns, same answer. Then they call the Miss, same answer. Then they call the Sturgeon, same answer. Now all the sites that could handle them have said no. So for a while, administration in Edmonton Zone was just saying, tough. You got to take it at U of A, or you got to take it, and then those patients were coming really sick from a hospital emerge to be dumped in the waiting room but and EMS would transport them and have to dump them and have to go back because they got to go service their community. And so that was happening more and more and more to the point where we're saying, okay, listen, the Edmonton zone, those doctors have no ability to tell Rapid, the place that helps us transport patients around, and Rapid North, to say, hey, we're really bad. Maybe consider calling Calgary or call Medicine Hat or bypass us. And then when you go and ask anybody in charge of the system, AHS leads, CA, Covenant Health leads, ACA leads, say, who's doing that for the IOC in Edmonton to help coordinate it? Their answers full were like, it's not me. It's not me. ACA is like, we're governance. It's not me. And now I think they're going to try to sort that out, and they're going to probably pretend like they got it all figured out quickly because they don't want to be embarrassed to make it look like they didn't have it under control. But I'm just saying flat out, they didn't. And that was what one of the options that we were begging for help for. And then I'll just finalize that with a point. That's someone's loved one, their mom, their dad, their son in Hinton, that or Edson or Northwest Territories or Camrose, wherever, that is sick and dying and needs really timely care and needs to be transferred in, and there was no way to coordinate and do that.
Yeah, I could go through all of these cases and just like one by one go like, oh my God, like this the second one that you have, the bowel obstruction. That's like one of my first codes was perforated or exploded bowel obstruction.
Yeah.
And those are the worst codes to work ever, for a
Yeah.
very long list of reasons. And again, like I look at this poor person who waited 8 hours over a night shift to be seen. She had the bowel obstruction perforation. And again, that's another one that had that been caught earlier, it can be a sometimes fairly simple fix. Um,
Absolutely.
if not caught, it can be catastrophic, and then in the case of this poor woman, result in death. Um, which is again like that to me is another one where I go, I don't know how anyone can, with a straight face, make the argument everything is working the way that it's supposed to. It's just extreme stress. Because when you have these preventable cases, and I don't want to say I love that you front loaded the document with those, but I think it makes a very strong argument, because all of these are preventable. All of these deaths are preventable with the right intervention applied at the right time. If they'd gotten uh, into the system, and we had a conversation with Dr. Raj Sherman, he did a very good job of highlighting once you're inside of the system and the process is processing, then you tend to get like world top of the best world care. but getting into that system that's so backlogged is unbelievably and unnecessarily, I would argue, challenging.
No question. And again, like there's been long times where people would, equivocate and there'd be a little bit of back and forth. And where are these suboptimal cases? Could they have been saved? Like my colleagues and I are all saying, listen, those examples at the front, there are strong opinions as if we'd intervened sooner, almost certainly those cases, those people could have lived, and probably would have lived. Um, and the sad part again, I want to highlight like those are just some of the examples. We're seeing lots of those and many of them. And I want to echo. I've said this a ton, but I hate being this doom and gloom, always talking about what's not working. Because I do, again, the reason we're talking about this, Nate, the reason why I'm not being paid to be here. I just finished 10 shifts in a row in Emerge. I'm exhausted. And not only that, is while this gong show was going on, and I've been talking to media and I've been trying to talk to my colleagues and trying to advocate while I'm in the middle of 10 shifts in a row. That's my real job. But the reason I'm advocating is because the system is like we do amazing work when you can get into it. And I'll tell you, like the cases, like there's a case on there that's not Mr. Sri Kumar, but that's very identical to someone in their 50s, severe chest pain, waits 8 hours, and then comes into the emergent collapses. I want to say I've seen those cases. These are, you know, as an example, an aortic dissection, so people can understand that that is the big aorta, the big artery that comes off your heart. You can get tears in it, and it can cause a lot of pain. But your ECG can be normal, your troponins can be normal, your even your chest X-ray could be normal. It may have changes, it may not. But the whole point about it is we know that that's a very sinister, life-threatening condition. That if we don't get you into a care space where we can get an expert. This is what our jobs are, to do diagnosis, to physically examine you, check your blood pressures on both sides, examine, listen to your heart, get your history, get all these things and be like, I think this might be a small tear in your heart, and I want to get you off to a CAT scan before it opens up. And putting it in the bluntest terms, if that tear fully opens up, you just pour all your blood into your chest and your belly and you die. Like that is what we want you to stop prevent. So if you get in quickly, you see someone like me, have I had cases like this in medicine at? And absolutely within minutes, I get them in Emerge. I see their blood pressures are different. I put them on very specialized blood pressure medicines to really bring them down. I have nurses that can do one-on-one care. I get them to a CT scan quick. And even in my environment, we can't fix that in the hat. But then I call you and the transport teams, and we have a great team and a crew that comes and flies them on a fixed wing with very specialized medicines, again, to keep them chill and keep their blood pressure down to stop that little tear from getting bigger. And then they get on a hospital table in an OR in Calgary and they get a graft or they get some type of surgery that saves their life. That is how the system works. Have I participated in that many, many times? Absolutely. And even I've given stories in the last couple of weeks. I've given thrombolysis, so a clot buster medicine to a heart attack patient that my colleagues in EMS identify. These are big heart attack, race them in, see them and lyse them in 10 minutes, give them clot busters in 10 minutes, and then get them to Calgary to the cath lab in 90 minutes. Like that's miraculous. It's amazing what we can do if the system is working. But the reason we're discussing all this is if you have any of those cases and those examples I just gave you, and you have a waiting room of 70 people and you have no space in your entire emerge department to put that next patient in, they die. And or they suffer and have lots of pain and have long-term bad side effects because of delayed care.
Yeah. Yeah, that sums it. What one of the examples that I like to use with people to help them understand like how amazing our healthcare system can actually be, and I think that's part of. I'm going to ask you to correct me if I'm wrong, but I think that's part of the advocacy that we're seeing from yourself and other people in healthcare because they know how amazing it can be when it is allowed to work unencumbered by all of the other things. I always like to talk about strokes because here at the
Yeah.
foothills like
Yep.
they literally can just go all the way up into your brain and suck out a clot that's starving your brain of oxygen. And that is some like they used to make movies about that
Oh,
in the
absolutely.
60s. It's
Yeah.
like science fiction.
And when they do that, your life changes from never speaking properly or using the whole side of your body for the rest of your life, and not being, not even be able to do self-care or mobilize, and like really significant, really, if you live, you could die too, but if you live, really significant impairment to like sometimes almost full recovery even, right? That's what we're talking about. But and I always say this, and it bears repeating too, is that there's almost nothing that's an emergency condition. Well, no, I'll even say it. There's nothing that's an emergency condition that gets better by prolonged waiting. Like we need to intervene. That's the whole point of an emergency. And so now routinely every day, I and my colleagues are seeing many patients that we can immediately dive in my, and I'm talking to my paramedic colleagues, my nurse colleagues, triage, and you name it. Throughout, we can immediately eyeball someone and say that person's sick, we got to get some stuff going for them, and we can't because of the system wide block. And I want to say too that I want to pull that out. Is emerge is the symptom, like we own the sins of the system. So everything that doesn't work properly in the system ends up in emerge. But my colleagues up on the floor in internal medicine and hospitalists, they're seeing the same impacts, and they're overworked and overcapacity and under resourced. And my colleagues in trauma surgery are calling me now and saying, like, Parks, the my waiting list for complicated ortho trauma surgery we've got 25 people on the trauma list. Like normally you'd get those down in 12 to 24 hours to zero, and they're like, we can never catch up. We got 41 patients out in the community with like severe, like trimalleolar, like all the bones broken in their ankle and can't walk, waiting a week, 10 days, 14 days to come in for surgery. They're begging for help because they can fix those people and do amazing care. Just we need the system to be able to do it. And then that I'll just put the last point on this. The only way now that we can fix this system, and anybody out there listening, this is a key take home, is the government has to help us. The government has to do the big, wide, system wide activity, empowerment, and solutions. There's no individual healthcare worker or hospital or site that can do this on their own.
And that brings me to the baffling press conference that we saw just a couple of days ago with Big Nixon. Um, because like here's the thing. I don't know that there's any reasonable people that are debating over the causes of the current problem. And again, I'll go to the example Dr. Rush Sherman used, where he talked about like it's like a logging thing. If you have a
Mhm.
place in the logging machine that does not move, then you cannot move the rest of the logs through. I mean, it works.
Yeah,
And
simple.
foundationally, that's what all of the experts that I've seen, all of the physicians, all of the healthcare workers, they're all saying we cannot move patients through. We have these alternative level of care patients that need care that they don't need to get in the hospital, but it's not being provided anywhere else. And so they stay in the hospital, and that backfills the hospital. And then, as you said, the ER owns the sins of all of the rest of the system. Um, and it was bonkers to me to watch Nixon try to do like wordplay with alternative level of care. Like when everybody and their dog has said, here is what the problem is. Please do something to address the problem. And you come back with, well, technically anybody can be alternative level of care once their primary problem is resolved. Like somebody's being discharged from the ER, they're technically alternative level of care. That does not instill in me confidence that they're taking the problem. Like when you're playing word games and turning it into a bad debate, that does not suggest to me that no, we're taking this seriously. But I want to hear your thoughts on all of that.
Yeah. Well, I got to be straight up on that one, Nate. Like I was scratching my head in that. I actually don't know. I truly don't know, having watched that, does Minister Nixon not understand what an ALC is, and not like doesn't actually understand like unbelievably critical fundamental piece of his ministry that's impacting the acute care world? Does he not understand it, or was he trying to wordsmith and downplay and try to, uh, blow off the significance? Because I can't tell watching that, but I gotta just say, for anybody out there, like, As you said, you could give. Let me just give an example of an 85-year-old that has a severe pneumonia that has just been barely managing at home, and they have multiple stairs, and they have all their stuff, and they're just barely getting there. They have other medical conditions, and maybe a little bit of dementia starting, and lots of issues. But they come into hospital for the pneumonia. We treat them for 5 days, get them way better, but they can't ambulate safely. They can't get back in their house. They can't go do stairs. This is one of thousands of examples, but I want to be very clear that they are medically done their care and they are ready to go home, but there's nowhere safe for them to go. Maybe some people are lucky and have family members and say, "Hey, come to my house and we'll get you a bit better and we'll fix things up and we'll take you home and we got resources." Or maybe it's just they need a little bit of home care, or maybe it is they need assisted living, or maybe it's actually no, they need a permanent long-term care. That those are the people that get designated alternative level of care, and it could be any examples, including mental health. It can be complex needs, but first off, right off, to just spell Minister Nixon, no, it's not a part of hospital admission and everybody becomes ALC. No, like when you're better, if this was you that had a pneumonia and 5 days later you're better and you don't need oxygen, we send you home. That's called a discharge. You do not become an ALC. That's a discharge. And we do it every day. And so that's the first thing to really understand. And then the second is, why would we focus on ALCs? There's no question. Anywhere, the national literature, anybody that's looked at this, uh, one of the big bottlenecks is these ALC patients. And I want to say they are not bed blockers in the sense of they are a bottleneck, but they're human beings that are stranded in acute care. And I also want to say they get charged. As soon as they're designated ALC, they actually pay out of pocket assisted living rates and costs while they're in hospital, while they're not able to go down and aggregate with other people, move around. They're stuck in a hospital. They get worse. They get sicker for being in hospital. There's a million reasons why they shouldn't be in hospital. All of the literature says the biggest bang for your buck to fix acute care flow, because a hospital bed is anywhere from the average of publicly we're spending $1,000 to $1,500 a day. An acute care a long-term care bed in a community, maybe $150 a day. Depends. So you vary it. But you can see the tenfold savings right away. And you can see why if you now think just pure numbers, let's just talk math. Let's just talk math. Across our province, maybe we have about 255, and when things are really bad, admitted patients stranded in the emerge. We call them EIPs, emerge inpatients, stranded in emerge. But we have 1,200, 1,400, 1,500 ALCs stranded in our hospitals. You can see the bang for the buck right away. If Minister Jones and his team and investment and getting workforce and capacity in long-term care could take 400 patients out of our ALC right away, make them go, but don't replace them with people out in the community that need to come in and all these other things, make them permanently disappear, you'd have no admitted inpatients in our emerge and it would flow. So it's simple math. Then it's simple math. And it's also for all those fiscal conservatives out there, it's way cheaper. But here's the last piece that does blow my mind is he said that there's nobody in emerge that's ever an ALC. Well, come on, man. Like we have so many. I mean, I'm certain, have picked up patients from facilities where they are like, we are not taking this person back. They need a higher level of care. Take them to emerge. As soon as they come in the door to see me, I know that their only need, we use words like failure to thrive, or we need an increased level of care. And we have all these euphemisms and terms, but I know as soon as I see them, there's nothing medically wrong with them in the sense of they have medical conditions, but there's nothing that's changed. There's nothing acutely new. There's nothing that needs an emergency department. All of a sudden, the emergency department is the safety net for Minister Nixon's entire ALA org. Just send them into us, and their ALC as soon as they register in the emerge. And for him to say there's no ALC patients, I'm sorry, as I'm talking, I might be screwing up ALA and ALC. The assisted living Alberta and the alternative level of care patients, as soon as they register, they become an ALC patient. So I don't know. I'll go back and I'll ask you, Nate, like, and ask the listeners, like, does Minister Nixon not get it? or was he trying to downplay and try to trick people that it's not a problem?
I would make the argument both of those suck as options. I mean, like
Yeah.
if you've got a minister who doesn't understand and thinks he does understand, like I always go back to there's a really great documentary called The Unknown or The Unknown Note. I can never remember it because the bit at the end always confuses me. But the whole idea is you don't know what you don't know, and knowing that you don't know what you don't know puts you in a much better position to address any problems. And for a minister of the crown who's responsible for such a pivotal part of this system to be either unaware that there are things that he doesn't know and perhaps should not speak with authority, or to deliberately try to spin Albertans, both of those are terrible. Both of those are incredibly cynical approaches to a very real problem. And in the wake of the leaking of this document, to go like, "Oh no, it's fine," or "I might be an idiot," is that's an incredibly bold uh, position to take, and I would also one that's probably disqualifying. I got two other things I want to ask you about real quick. One of them is the triage physician piece, because this is being touted as this is going to save everybody. And like, I'm looking at it and I'm going, "We don't know about that." This seems to me to be a emergency measure that is, again, an admission that the emergency room cannot handle, like the emergency room proper, not the waiting room, if we divide it into
Yep.
those two sections conceptually. The emergency room cannot handle the sick patients that need to be seen right away. So instead of, I don't know, dealing with any of these ALCs or the other issues, they're very hard to understand, apparently. Instead of dealing with those, we're going to put a physician in the waiting room and expand, in effect, the footprint of the emergency room into the waiting room in order to try to catch some of these cases or similar cases to the ones in the document, and try to prevent some tragic outcomes, which is, I think, a good thing, but also an admission that there's a crisis. And my follow up that I'm going to ask you to talk about is um, there's no new staff for this role. We're going to create some extra shifts and we're going to cross our fingers that the docs who have just finished working 10 shifts in a row are going to go, "Yeah, sign me up for more. I want to hang out in the waiting room."
Correct. Correct and correct. All the things you said are correct. It's important. Let's put some perspective on this and historical. We've had the TLP. It's a triage liaison physician. It's a waiting room doc, a merge waiting room doc that we've had it in the past. And it was a temporizing measure. Government unilaterally canceled it in 2013. And that caused some headaches, but we've had it in the past. So it's an old idea. It's really important for people to understand while we've been talking about how we've been warning government for over a year, saying that this is we're really overcrowded. Things are really, really bad. My colleagues in Edmonton and Calgary have been pleading for the triage liaison physician as a mitigating strategy for over a year. It's been sitting on a bureaucrat's desk. It's been on one of the minister's desks. I think somehow it might even be on Minister Lagrange's desk, despite we have Minister Jones as the ACA lead, because that's how I'm telling you how disconnected it is right now, because they truly don't know who's running what or what's doing what. But for over a year, my colleagues have stepped up and said, this will be something that will help a little bit while it gives us some time to do the back end fixes, because we don't want to see patients dying in our waiting room. And also, we want to show some solidarity with our triage nurses and our EMS colleagues and the people that are stuck out in the waiting room trying to come say, let's see what we can do to try to mitigate this. So it's a band-aid on a huge gaping wound. It will not fix things. But it will help us catch some of those examples and some of those cases. But again, you have to think it's in itself, it's putting a physician out there to go, yeah, you're really sick, you need a room. Yeah, you're really sick, you need a room. Oh, there's no rooms. But maybe it allows us to be, oh, that chest pain sounds like it could be a dissection. I'm going to race you to a CT scan, even though I haven't really really done the best proper assessment and everything, because I'm going to risk and balance it, and I think you're high enough risk. I'm going to get some of these tests. So, as an example, I've been a triage liaison physician before at the U of A. I've sent appendicitis from the waiting room to the OR as the triage, like diagnose, put my hand on their belly in a chair, get a bit of blood work, send them to CT, and they go straight to the OR. That's the stuff we're talking about. I've sent a AAA, a ruptured AAA from the waiting room to the OR. These are the kind of things you're going to try to mitigate and do a little bit here and there in the busiest, worst off emerge departments. But it's a temporizing measure while we do all the back end, bigger provincial wide stuff that we can do and the medium and long term stuff we can do. And then you're right. We are like, we're losing so many of our great nurses. Like, when people talk about the moral distress right now, I have had so many colleagues reach out to me, nurses, saying, Paul, I've 20 years, 25 years as an emerge nurse. I'm going to do home care. I'm leaving to do this. I'm doing that. I can't, I'm just burnt out. I can't do this, see this every day. So we're losing really, really good nurses. We're understaffed already. We don't have enough emerge physicians already, too. And we're going to be asking the teams to step up and do more. And so what's critical is our teams are willing to do it to a degree, but we're saying resource it properly, and we're saying be aware that it's just a temporizing measure because we're in a crisis or a disaster or a state of emergency. We're going to implement this to try to mitigate disaster, but please help us out, resource it properly, and help us out on the background, on the back end. And like I said, it's been on a desk for over a year, and all of a sudden, after they decided maybe we're not misguided, after they decided to stop gaslighting us, after they decided to stop downplaying everything, all of a sudden now it's an emergency to get that rolled out.
My last question for you, sir, because I want to be very respectful of your time, especially given that you're coming off of 10 days. Um, Rick Bell, and I have some complicated feelings about Rick Bell. I really do. Because, like, back in the day, this is the thing that I wish he understood. Back in the day, Rick Bell was like the guy who spoke truth to power. He had the fedora and he had the trans. I really, really, really liked Rick Bell a lot. And then I don't know what happened, but he became, in my view, in effect, a stenographer for Danielle Smith. I get that he seems to like Danielle Smith very much, but he became a stenographer, and it seems like he gave up that truth telling. But he put out a column a couple of days ago where he talked about his experience in the healthcare system and was shocked at how cumbersome it was for him to get the care that he required for what he described as being. I mean, if he's actually running around with the DVT, I don't need to tell you that's a spicy meatball potentially. Again, another one that, if caught, if treated, can turn into a nothing burger, but if left, can turn into dead. Uh,
Correct.
and he did his column where he was like, "Hey, you should get Danielle Smith. You should get the Sheldon Schumer an ultrasound," and I, that would be good. Um, but I'm terrified that he's going to come out with a column in a week and be like, "Yeah, Danielle Smith got the Schumer and ultrasound. Everything's fine." And it's like, "Oh my God, no." It's so much bigger than that. If you could speak to Rick Bell, uh,
Yeah, absolutely. Like, so I'll say kudos big time that he wrote that and got that out there and shared his personal experience. I'll say that I've been here 25 years, and as you say, Rick has been he's the major supporter of publicly funded healthcare, and he's been a tiger since even in the 90s and probably before. Around blowing up hospitals in Calgary and being and holding government to task and really giving it to them over the years. And yeah, I think the key part here that I really want to focus is I think it's amazing for two reasons that he wrote it. One is just to share his story, and so I want to say that story is not in any way atypical. That story is not like, oh, I just had this is a bad day, one off, and oh my goodness, It wouldn't surprise me if he suddenly gets like finding out he doesn't have a family doc. It wouldn't surprise me if someone influential pulls some strings and he gets one, or all these things. So him being a writer that told that story, it's really important and critical that he did, because first off, it's not atypical. I could go through some of the troubles he had. Second off, it is that's like uh, it's critical that who's reading Rick Bell actually understands what's going on as well. That I think the he has a wide readership, and he has what I don't say this in disparaging. Your average working blue collar person out there is maybe not aware of what's going on in the healthcare system until they need to access it. And the best example would be the, call it 30 to 40-year-old, let's call it 20 to 40-year-old males. We're invincible till we die. We don't go see docs. We don't think about our health care. We don't think about anything. And in fact, that maybe we're hurt at work and have to get some stitches or things like those are the people that are reading his columns, and he has a wide readership. It's not just them, but they, I've said this again and again and again. It's people don't know what they've got until it's gone. And now more and more and more people are trying to access healthcare. They're trying to call an ambulance and finding out there is none for 2 hours. They're trying to go to Emerge and finding out it's a 10-hour wait and they're still not getting their full care. They're trying to get cancer care and they're getting the chemo bumped and they can't get into a cancer specialist for 8 months. People are not realizing what our system looks like until they try to access it, and it's way too late. So I think it's awesome that Rick's writing this, and he's writing it in plain spoken, really direct kind of language that everybody's kind of saying, "Hey, I can see that. I can see what's going on." I agree with your summation though too, and me, if I could reach out to Rick and talking to him, it's not about that ultrasound machine. Like that's the thing. I've said this forever. It's about, so as one example, ultrasound and what he highlights on is really a critical issue for all of our emerge departments, because we can't get after hours access to really important life-saving ultrasounds after 4 p.m. because we don't have the technologists. We don't have the human beings to do the tests. And that would be applied to whether it's an ultrasound or whether it's, dialysis or respiratory therapists or physiotherapists or the human beings. You can have as many machines that go ping and bong, and you can have ultrasound machines, but if you don't have the human beings to do them, they're useless. But then even more so, let's tie this back to the people who are voting for Daniel Smith and reading Rick Bell's articles. Our premier over the last 3 years is doing everything she possibly can to, first off, not plan workforce, not think about it, not do it in a strategic way, but to drive all of our ultrasound techs out of the hospital. As an example, she's decided that they are going to privatize access to DI and labs, and they're going to let anybody, regardless of whether they need it or not, walk into a place and order an ultrasound and pay for it. I can tell you right now, anybody looking at the healthcare system with even a sniff or a whiff of an idea of what's going on will tell you that every single one of our techs will go work 9 to 5, Monday to Friday, no call, easier cases, not have to go see that, really crashing 28-year-old with a pregnancy that's bleeding and dying at 2 in the morning. And every one of our techs will go do that. There'll be a couple that are love the trauma or love this and maybe stay, but the vast majority will go and work in the private stream, and we'll have nobody left in our hospital system to take care of you when you're sick and dying or your loved ones. And so, kudos to Rick writing that story, and I think it's important. And you know what? Last thing, I know you probably have some more comments, but the probably the most important reader of that article is Premier Daniel Smith, because she reads him and pays attention to him. And I'll say she loved to pontificate and to get out in the front and talk about everything. Her silence has been deafening on this healthcare crisis. It truly deafening. And there's over 100,000 healthcare workers, probably more, that are all very much hearing her non-response right now.
I just want old Rick back. That's what I want. Like
Yeah.
it really is. That's that because like and I don't mind saying this. It's I oh, in the 90s and the early 2000s. Um I look at what Rick Bell did, the tone and the tenor with which he dealt with politicians who were playing the sort of games that we talked about with Big Nixon playing earlier, assuming he's not incompetent, 50-50. But that is in no small part inspiration for how the breakdown operates. And to see it's like there's this little taste of like old Rick back, and I just want come back, Rick, come back to the good side. We'll get cheese and crackers. It'll be delightful. Because he used to be just such a powerful truth teller, and it hurts me to see the stenography when it happens. Um, Anything else that you want to hit on? Anything else that you want to talk about before we wrap it up?
Yeah, you know what? One thing I do, we have solutions. We have lots of good ideas. There's lots. I'm not going to go into it. Healthcare is really complex. And as an example, I mean, if someone has to give primer to Minister Nixon about what ALCs are and what how that impacts the acute care world to help us out of this disaster and what ALA world can do, please someone do that. But what can your listeners and what can Albertans out there do? I mean it. We this is a plea for help. This is healthcare workers saying we need help, and the only person and the only people that can actually mobilize resources and do this in a concerted way is the provincial government, and it's the premier and her team. And so they're not listening to me. They're not listening to the vast majority of healthcare workers. So maybe they'll listen to Albertans. And so I think Albertans have to start talking about this, get vocal about it. But if there's three things you want a really simple, easy solution right now that everyone can demand is demand transparency on a couple key data points. Demand transparency right now. If you want to know how our acute care world is flowing, so this means getting into emerge, getting into the hospital, cancer care, surgery, anything that has to be done in the hospital, the three things that will, the best metrics right away, first one would be our EIPs. So that's our emerge inpatients. Have them, they track this every day, they have it. Transparency. Publicly, Minister Jones has told me personally multiple times he's a fan of transparency. Publicly publish how many admitted inpatients, EIPs, each emerge major emerge department has as a proportion of their funded base. So U of A has 65 funded care spaces for their emerge. If they have 50 EIPs in there, show that every day. Do that for our major ones because that tells us how congested and how bad our emerge department is. Very, very transparent, clear, and that gives us a metric and marker of how the rest of the system's doing. Second one, ALC numbers. Minister Nixon got up there, it's down by 15%. If it is really down by 15%, they should be singing those numbers to the mountains and showing us. So what are the ALC numbers in the hospitals? What's the definition of them? Is it the same for the whole province? Because what's happened, there's some concerns that some of our ALC numbers dropped because they changed the definition and the patient's still in the hospital, but not designated ALC anymore. I don't care in the end now, define it. Tell everybody how many ALCs patients are in our major hospitals. Do not aggregate these. Don't say, hey, on average, out of the 100 hospitals we have in Alberta, it's X percent because lots of the small Alberta hospitals don't have many or lots have lots, and it doesn't tell us what's happening at the big centers that need to be able to function. So our EIPs, our ALC numbers, and then an actual true meaningful hospital capacity. What is our actual bed base that functionally we can use? Because they know they can't flow into maternity or into ICUs. And so they know functionally how many hospital beds are in a hospital. Bike medicine hat for me, is it 200? Is it 180? Functionally, how many beds do we have? And what's our capacity day to day? Those three things, they track them, they have them. If they publish that right now in clear, transparent way, then we will know immediately as taxpayers and as people paying attention to this, are the things they're doing, are they helping us get better? And so that people can get meaningful access? Is it trending better and is it working or is it getting worse? That's the easiest start. And that's what I would beg people to say, demand that. It's our money. We're paying for the system. Demand they show. No more of this. Don't let them get up there and dog and pony say 15% this and us is this. And hey, you know what? We're announcing another 1,000 beds. We're going to get towers, 1,000 beds in the Miz and the Nuns. Those will come in line in 2035 if we're lucky. If in 2 years when we have election and the government wins again and they decide not to cancel it, which I'll tell you, we would have had beds online right now in Edmonton. The NDP, I'm not that 2017 NDP created a hospital, started digging a hole, started going. Kenny paused it. Smith killed it. We have no beds coming on in the Edmonton zone right now. Don't let them promise beds. Don't let them do this. Let them sing and do and dance and do all the things they want to do as politicians. Show us those numbers and show us, is it getting better or worse?
Dr. Parks, thank you so much for taking the time to chat today. I really, really appreciate it. I hope you get some rest. Hopefully well, we're going to stay in touch. So
Absolutely. We can keep chatting. And I will leave by saying I did not give you those cases.
no, you didn't.
I know. I'm sure maybe government doesn't believe that, but I didn't. But that's okay. Whatever.
I'll put an affidavit up. I don't care.
It's important. Anyway, I appreciate it, Nate. Like, I think more and more people, we just got to get the words out in different ways. And I think people need to understand what's going on in the system.
100%. Thank you so much, sir.
And that's it for another episode of The Breakdown. As always, if you appreciate the kind of content that we're trying to produce here, we would love nothing more than if you thought about signing up to be one of our Patreon sponsors at www.patreon.com/thebreakdownab, where for just the price of a fancy cup of coffee a month, you can help us continue to produce this kind of content. Whether you're listening to the audio version of the podcast, in which case maybe leave a review and a rating, or whether you're watching it on one of our streaming platforms, we want to say a big thank you to everybody who is part of the Breakdown's audience. And as always, take care of each other and keep the conversation going.